Okay, welcome to this part three of uh, CNS infection or meningitis. We have discussed in part two about uh, the clinical features of meningitis, about how to make a diagnosis of meningitis, and how the CSF findings differ from one another based on the responsible etiologic agents, and also when you differ lumbar puncture and you do brain imaging. We have seen these things in our lecture in part two. And this part three of this lecture series, we will see about the treatment of meningitis, its acute and chronic complications, and the prognosis of meningitis, and the prevention mechanisms, how we can prevent meningitis, and vaccines that are possibly available in our world currently, and the special populations that need special attention uh, to treat and make early diagnosis of meningitis. So, when you come to the treatment or the management of bacterial meningitis, the mainstay of therapy for bacterial meningitis is in antibiotics. So, as much as possible, if we suspect bacterial meningitis, we have to start broad-spectrum antibiotics as early as possible. So empiric antibiotics should be initiated immediately. Then we can taper down. We can discalate the antibiotics based on etiologic findings if the culture result can reach early from the laboratory. So empirically, we treat this bacterial meningitis with we start with ceftriaxone plus vancomycin with or without ampicillin, with or without ampicillin, because uh, giving ampicillin is not for all population groups. So those special population groups which need addition of ampicillin are those who are at risk of developing Listeria monocytogen infection. So you add ampicillin on ceftriaxone and vancomycin in a patient in whom you are suspecting this patient is at high risk of having Listeria monocytogen infection, like old old age, pregnant mothers, and children children also, especially in neonates. In this group of population, they are at risk of having this Listeria monocytogen infection. So we add ampicillin to cover this Listeria. I'm sorry. The other important thing that needs to be mentioned is corticosteroid use, or dexamethasone. Currently, it's almost out of practice. Currently, using steroids in treatment of meningitis, because it is benefit is not uh, proved with recent studies, and especially in sub-Saharan Africa, like in our country, where the people come with history of antibiotics take before coming to the health facility, and where there is a high prevalence of malnutrition. The use of corticosteroids currently it is under question. In fact, in most of the practices in our country, in the hospitals nowadays, corticosteroids are not being used in the treatment of bacterial meningitis. So no need of using steroid. The other thing is we will discuss about viral meningitis. So about the viral meningitis, just it is a supportive care. You give supportive care, and if the etiology, the viral etiology is like herpes simplex virus or varicella zoster virus, you can use acyclovir, IV acyclovir. Usually, this IV acyclovir is not available in our country. Usually, sometimes we use oral acyclovir, even though it's not effective. The recommendation is to use IV acyclovir. And In fact, the good thing for viral meningitis is it is self-limiting infection. The other thing is fungal and TB meningitis. For fungal meningitis, we treat with antifungals like amphotericin B plus flucytosine. For TB meningitis, we use anti-TB with steroids. Anti-TB with steroids. The first line anti-TB medications like rifampicin, isoniazid, ethambutol. These are the first line anti-TB drugs. So they are used in the treatment of tuberculosis. Unlike that of pyogenic or bacterial meningitis, the use of steroids in TB meningitis is recommended here. So, uh, uh, use of steroids in TB meningitis is part of standard management of TB meningitis. So, it's not like that of pyogenic meningitis. In TB meningitis, you have to use steroids. You have to use steroids. The other thing is in these conditions, in fungal, in TB meningitis, the treatment needs somewhat prolonged period. It's somewhat prolonged period for TB meningitis. For example, you treat the patient with anti-TB for 9 up to 12 months, which is very long, and that needs the patient's drug adherence. Drug adherence. So in usually patients with meningitis, they need supportive care because this group of patients, especially in developing countries, due to they present late with change in mentation and they might be comatose with loss of consciousness. So a lot of supportive cares are needed. You have to give fluid if the patient is hypotensive. You have to give antipyretics to control the fever, and pain management is also important. Monitoring for complications and ICU admission may be required based on the patient's clinical condition. You may decide the patient to admit the patient to ICU. So if the patient is like changing, if there is change in mentation with low GCS, you have to give attention for feeding as well. For feeding, you have to give attention because a patient may die of hypoglycemia if you ignore feeding. So in such group of patients, supportive cares are very important. With this, let's see the complications of especially pyogenic meningitis. We classify the complications as acute complications and the chronic complications. From the acute complications, you see septicemia, increased intracranial pressure, seizure, hydrocephalus, and cerebral edema that which may lead to cerebral herniation, and they may develop stroke, and patients may develop subdural effusion or empyema, especially subdural effusion or empyema is common in pediatrics age group. In pediatrics, they may develop subdural effusion or empyema. So search for the complications. Possible complications should be sorted out in patients with meningitis. And patients may present with cranial nerve pulses. Cranial nerve pulses could be possible acute complications of meningitis. The chronic complications like cognitive impairment, hearing loss, motor deficit, and seizure disorders in the future, and visual problems and behavioral changes and emotional disturbances could be possible chronic complications of meningitis. And the patients might develop chronic headache in the future, for which they will live with it. So that needs special attention. So when you see the prognosis, the prognosis depends on different conditions. The type of the type, which means the etiology. The etiology matters. For example, streptococcal pneumonia, the prognosis is very poor when you see the Listeria monocytogenes and especially strep pneumonia. Strep pneumonia has poor prognostic sign when you take in terms of etiologic classifications, and the treatment timing also matters. When you start the treatment early, you will make the prognosis somewhat better, and as the treatment goes more late, you will increase the mortality probability of the patient. So, and when in terms of etiology, bacterial etiology has high mortality and high morbidity when compared to others. And for viral etiologies, the prognosis is good relative to other etiologies. Uh, Let's see the prevention. When you say the prevention, vaccination is very important. There is vaccination for Haemophilus influenzae, pneumococcal vaccination, meningococcal vaccination, and sometimes prophylaxis may be needed, especially for patients with in the setup where there is meningococcal infection, and if you are suspecting meningococcemia epidemics, you have to give prophylaxis for contact for the contact patient, the contact family members, and sometimes even the healthcare professionals should take prophylaxis for meningococcal infection. And good hygiene also promotes your prevention from being infected with meningitis causing organisms. So the vaccine, meningococcal conjugate vaccine is there, PCV13 and PPSV23, Haemophilus influenza vaccine, and also mumps prevention, mumps vaccine is also indicated to prevent meningitis. So the special population, when you see the special population, neonates usually the meningitis is caused by group B, Streptococcus, and E. coli. In immunocompromised individuals, listeria and fungal infections are possible, and in elderly, the mortality is increased. In elderly, there is high risk of mortality from meningitis. So these are the special populations which need a special consideration when you are start evaluating the possibility of meningitis in this group of population. Finally, early recognition and the treatment are critical, and vaccination reduces the incidence of meningitis, and continue research into diagnostics and therapies are the current recommendations that we need to do to improve our patients' outcome and improve the better treatment modalities. Thank you very much. This is in fact, the final part about meningitis. So, if you do have any question, anything that is not clear, you can ask me at any time. You can write your comments below. I want to say thank you very much.